I was looking at the global health data regarding parasites this morning, and I stumbled across a number that I actually had to double check.
Oh, the helminth infection rates.
Yeah. The source material noted that over 1 billion individuals globally are currently infected with nematodes.
Wow.
And that is billion with a B.
It is a staggering statistic. Combine Ascaris, hookworm, and trichuras, you were looking at one of the most massive biological burdens on the human race.
Exactly. And for everyone listening today, whether
Right, because we aren't just going to list growth worms today.
No, definitely not. We are going to dissect the diagnostic strategy.
Because in a clinical lab or, on a board exam, you rarely completely identical to 3 other larvae, and you have to make the call.
And that is the mission today. We're going to break down the lookalikes, the really subtle morphological clues, and the specific quality assurance protocols that keep you from misdiagnosing a patient.
It's so critical.
But before we start digging through stool samples, we really need to set the biological stage. When we say nematode, we aren't talking about tapeworms here.
No, absolutely not. Tapeworms are cystodes. They're flat and segmented.
Groups is the body plan. It's the tube within a tube concept.
Exactly. Unlike the others, nematodes have a complete digestive tract, mouth at one end, anus at the other. And crucially, for identification, they are dioecious.
Which is just a fancy biological way of saying they have separate sexes, right? Male and female.
Correct. Which is a huge clue if you were lucky enough to actually see an adult worm.
Okay, so we have a complete gut, separate sexes, and a cylindrical body. Let's break this down, then we'll move to tissue, and finally blood.
That is the logical workflow, yeah.
All right, let's look at the first slide from the source. The most common helminth infection in the United States, especially in temperate zones and daycares, Enterobius vermicularis,
The pinworm.
the bane of parents everywhere.
Truly, it's so highly contagious in those group settings for kids like 5 to 10 years old.
Now, for the boards, the trick here isn't identifying the worm itself, but the collection method. You don't look for Enterobius in a standard stool concentration, do you?
No, and that is a guaranteed exam question. If you order a standard stool O&P for pinworm, you're going to get a false negative almost every time.
Because of where it lives.
Well, the female worm has a very specific behavioral pattern. She lives in the colon, but at night she migrates out the anus to lay her eggs right on the perianal skin.
Which perfectly explains the primary symptom, that intense perianal itching.
Right, and that itch is actually part of the transmission strategy. The child scratches in their sleep, gets eggs under their fingernails, touches a toy, or puts their fingers in their mouth, and the cycle just restarts.
So because the eggs are on the skin, not mixed into the stool, we have to use the Scotch tape test.
High-tech medicine at its finest.
Hey, if it works, it works.
It really does. You take clear cellophane tape, and it has to be clear, not the frosted kind, because that obscures the microscopic view, and you press the sticky side to the perianal area first thing in the morning.
And first thing is the operative phrase here. You absolutely cannot do this after they've showered or used the bathroom.
Exactly. You need to catch the eggs before they get washed away.
Yeah.
But here's the internal quality assurance standard that trips people up. You cannot rule out pinworm with a single negative tape prep.
I saw that in the notes. The QA protocol requires 5 consecutive negative mornings to officially rule it out.
Yes, 5. The sensitivity of a single test is just too low. So if you're a clinician and that first test comes back clean, but the kid is still scratching every night, you have to keep going.
Now, visually, once we actually get that tape under the microscope, what are we looking for? The source describes the egg shape as planar convex.
Which is a very sterile textbook way of saying it looks like a loaf of bread.
Right.
Or a flattened letter D.
A flattened D. Yeah.
One side is totally flat and the other is rounded. If you see that D-shaped egg on a cellophane tape prep, it is 100% enterobius.
And the treatment for that?
Usually mebendazole or albendazole, but you typically have to treat the entire household.
Because it spreads so easily.
Yeah, the eggs are so light and infectious, they end up aerosolized on bed sheets and in house dust. It's a whole family issue.
Let's scale up from the little pinworm to the heavyweight. Ascaris lumbricoides. The notes say this is the largest intestinal roundworm, reaching up to 30 centimeters.
It's basically an earthworm living in your small intestine.
The sheer horror of that aside, the diagnostic challenge here usually involves the eggs found in the stool. And this is where students get really confused, because Ascaris eggs can look totally different depending on whether they are fertilized or not.
This is a classic morphology trap on the exams.
Yeah.
The fertilized egg is what you see in all the standard textbooks. It's round to oval, usually bile-stained to deep golden brown, and it has a very thick shell with a mammillated coat.
Mammillated meaning bumpy, right? Kind of like a rough tire tread?
Exactly. It looks rugged, scalloped almost. But if the patient only has female worms in their gut, you are going to see unfertilized eggs in the stool. And they look nothing like the fertilized ones.
How so?
They're much more elongated, they have a thinner shell, and often that bumpy mammillated layer is just messy or completely missing.
So you could be scanning a slide looking for a nice round bumpy egg, and instead you see this long, smooth, weird-looking thing and completely miss the diagnosis.
Precisely. You have to train your eye to recognize both forms.
Now, Ascaris isn't just an intestinal problem. There is a phase of its life cycle that mimics a respiratory infection. Loeffler syndrome.
Yes. This is the why behind some very confusing clinical symptoms. When you swallow an infectious Ascaris egg, it hatches in the gut, but the larva doesn't just stay there.
It goes on a road trip.
A very destructive road trip.
Yeah.
It penetrates the intestinal wall, enters the bloodstream, and hitches a ride to the lungs. It bursts out of the capillaries into the alveoli, crawls up the bronchial tree to the throat, and then you swallow it again.
That is an incredible amount of effort just to get back to the exact same intestine it started in.
It is. But that migration through the lung tissue causes an intense immune response in eosinophilic pneumonitis.
So you have a patient coughing, maybe wheezing, their lab work shows high eosinophils, and the doctor thinks it's asthma or pneumonia.
Right. But it's actually a worm infection migrating through their chest.
Wild. Okay, moving down the list to Trichuria, the whipworm. This one seems to have the most distinct egg of the bunch.
It really is the easiest to spot. It's barrel-shaped or football-shaped with a distinct clear plug at both ends. We call them bipolar highline plugs.
It kind of looks like a little lemon with the ends cut off.
That's a great way to visualize it.
But while the egg is easy to identify, the pathology is nasty. The notes mention rectal prolapse.
Specifically in children with heavy worm burdens, yeah. The adult worm is called whipworm because it has a thick, handle-like posterior and a long, very thin, whip-like anterior end.
Right.
It literally threads that thin end into the mucosa of the colon to anchor itself.
So it's physically sewn into the gut line.
Yes. And if you have hundreds of them doing that simultaneously, the inflammation and the constant urge to push, which is called tenesmus, can be so severe that the rectum actually prolapses out of the body.
That is a very vivid and terrifying image. What's the treatment for both Ascaris and Trichuris?
Again, the benzimidazoles, mevinizole or albendazole.
And how do those work?
They work by inhibiting microtubule synthesis in the worm. Basically, it prevents them from absorbing glucose, so you're essentially starving the worm to death.
Okay, we have arrived at what the notes call the biggest diagnostic headache in the intestinal section, the look-alike challenge between hookworm and strongyloids.
Oh yeah, this is where you separate the novices from the experts at the microscope.
Let's start with the basics. Hookworms, Necator americanus, and Ancylostoma duodenale. They enter through the skin, usually the feet, right?
Yes, usually from walking barefoot on contaminated soil. The filariform larvae just penetrate right through intact skin.
Now, typically, diagnosing hookworm is straightforward. You find the eggs in the feces. They're thin-shelled, oval, usually with cells clearly dividing inside them.
Correct. If you see a thin-shelled egg in a fresh stool sample, it's hookworm. Strongyloid stercoralis is different. Those eggs hatch inside the intestine. So by the time the stool is passed, you aren't seeing eggs anymore. You are seeing live larvae.
So the general rule of thumb for boards, egg equals hookworm, larva equals strongyloids.
In a perfect textbook world, yes. But here's the trap in a real clinical lab. If a stool sample sits on the lab bench for a few hours or gets delayed in transit before you look at it, those hookworm eggs can hatch.
Oh, wow. So now you have a sample with larvae actively swimming in it. Is it strongyloids? Or is it hookworm that just hatched because the sample is old?
Exactly. And you have to differentiate those larvae, specifically the rhabditiform larva stage. And you do that by looking at the mouth structure, the buccal capsule.
Okay, walk us through the morphological difference.
You need to focus on the length of that buccal cavity under high power. Strongyloids has a very short buccal capsule. It looks like just a tiny little opening.
And the hookworm?
Hookworm larvae have a long buccal capsule.
I always remember the mnemonic short and sexy for strongyloids, S&S.
That absolutely works. Or long hook, whatever gets you there on exam day. But you have to check that mouth structure and also look for a large genital primordium in strongyloids, or you will misdiagnose the patient.
And misdiagnosing strongyloids carries a much heavier penalty than missing a hookworm, doesn't it? Because of the autoinfection cycle.
This is the critical clinical difference. Hookworms, Ascaris, whipworm, they all need to leave the human body to mature in the soil before they can infect anyone again. Strongyloids breaks that rule. The larvae can actually mature into the infectious filariform stage while still inside the human gut. They can penetrate the bowel wall or the perianal skin and reinfect the exact same person immediately.
So you don't even need to walk barefoot outside again. You become your own continuous source of infection.
For decades. We see veterans from World War II or the Vietnam War who still carry strongyloids 40 or 50 years after they came home.
That's incredible.
They usually manage it fine until, and this is the absolute danger zone, they get immunosuppressed. Maybe they get high-dose steroids for asthma, or they start chemotherapy.
And suddenly that immune system that was keeping a lid on the worm population is just gone.
Exactly. And you get a hyperinfection syndrome. The worms multiply explosively, disseminating to the lungs, the brain, everywhere. It carries a massive mortality rate.
Which is why we treat strongyloids differently. We don't use albendazole as the primary therapy. We use ivermectin.
Right. Ivermectin is the drug of choice to fully clear that autoinfection cycle. And for hookworm, by the way, you also have to give iron supplements because chronic hookworm causes severe iron deficiency anemia.
Important supportive care step there. Okay, let's shift gears from the gut to the tissue. These are the nematodes where you aren't looking at stool samples, you're looking at biopsies or serology. And we have to start with Trichinella spiralis.
The hunter's parasite.
We usually associate this with undercooked pork, but lately I've read it's actually more common in wild game.
Yes, commercial pork farming practices make it quite safe now. Outbreaks today are almost always linked to homemade jerky or sausages made from bear, boar, or even walrus meat.
Humans are dead-end hosts for this one, right?
Right. We eat the infected meat, but nothing is going to come eat us to continue the cycle.
Now, biologically, this one is fascinating because of what it does to our muscle tissue. The larva insists in striated muscle, but they don't just sit there dormantly. They form these things called nurse cells.
It is sophisticated bioengineering. The larva enters the human muscle cell and actually reprograms the cell's DNA.
It hacks the cell.
Exactly. It forces the cell to create new blood vessels, a process called angiogenesis to feed the worm. It literally turns a striated muscle cell into a custom life support capsule.
That is terrifyingly brilliant. Diagnostically, we would see these coiled larvae in a muscle biopsy, but you mentioned serology is common too.
Serology is often easier than cutting a chunk of muscle out of someone's leg. But clinically, you want to look for the classic triad: a history of eating wild game, periorbital edema, that distinctive swelling around the eyes, and splinter hemorrhages under the fingernails.
Got it. Let's talk about the larva migrants group. These are animal roundworms that accidentally end up in humans.
Right. Humans are not the intended host. So when these larvae get into us, they get confused. They don't know the anatomical roadmap, so they just wander around. Hence the name migrants.
We have Toxicara from dogs and cats causing visceral larva migrans, where they wander through the liver and visceral organs. Its eggs have a thick, pitted shell. But the one that really scares me is Balasiscaris procyon, the raccoon roundworm.
That is definitely the one you need to fear. Toxicara larvae generally stay microscopic, but Balasiscaris larvae have a horrific trait. They continue to grow in size as they migrate through the human nose.
And they have a really bad preference for where they migrate, right?
They love the central nervous system, neural larva migrans. So you have a worm getting bigger and bigger while it tunnels through a child's brain tissue. It causes severe eosinophilic meningoencephalitis, and it is frequently fatal or leaves the patient with permanent brain damage.
It really emphasizes the whole One Health concept. Keeping raccoons out of your backyard or away from kids' sandboxes isn't just a nuisance issue. It is a severe health safety issue.
Absolutely. The environment, animal hosts, and human health are entirely linked.
Then there is the skin version of this, cutaneous larva migrans. This is known as the creeping eruption.
Usually caused by dog or cat hookworms and Celestoma brasiliensis. They penetrate human skin often if you're lying on a contaminated beach, but they lack the specific enzymes needed to break through our basement membrane and get into the blood.
So they just get stuck.
They trapped in the epidermis. They just crawl around horizontally under the skin, leaving these raised, red, incredibly itchy, supiginous, snake-like tracks.
Nasty, but thankfully self-limiting compared to the brainworms.
Yes, humans are dead ends, so they eventually die, but it drives patients absolutely crazy with the itch before they do.
All right, final section. The blood and filarial nematodes. These are the ones transmitted by insect vectors.
Mosquitoes and flies, mostly.
The biggest diagnostic factor here isn't just what you find on the smear, but when you look for it. We really need to talk about periodicity.
This is a crucial logistical challenge for the hospital lab. Organisms like Wuchereria bancrofti and Brugia malae, which are the main causes of lymphatic filariasis or elephantiasis, they are nocturnal.
And that's not random. That is evolutionary synchronization.
Correct. Their vector is a night-biting mosquito, often Anopheles or Culex. So the microfilaria, the baby worms, they hang out deep in the lung capillaries during the day. But between 10 p.m. and 4 a.m., they swarm into the peripheral blood, specifically to be picked up by a feeding mosquito.
So if a doctor orders a peripheral blood smear for filariasis and the phlebotomist draws the blood at 2 p.m.,
it's a wasted test. You will get a false negative. You have to coordinate a night draw or sometimes give the patient a provocative dose of DEC to force the worms out into the blood during the day. But night draws are the gold standard.
Okay, let's say we get the timing right. We have a gym-sustained blood smear. We see a microfilaria. It looks like a little purple ribbon on the slide. How do we tell them apart? Because they all look really similar at first glance.
The tail test is the gold standard morphological differentiation here.
Right.
You need to look at the very tip of the tail under high power. You're asking two diagnostic questions. First, is it sheathed? Does it have a clear wrapper around it? And second, where exactly are the nuclei inside the tail?
Let's run through the big three. First up, Wuchereria bancrofti.
It is sheathed, and the tail tip is absolutely clean. The column of nuclei stops well before the end, leaving a clear empty space at the very tip.
Clean tail equals Wuchereria. Next is Brugia malae.
Also sheathed. But the tail tip has two distinct nuclei that are separated from the rest of the body column. It literally looks like two little marbles dropped into the very end of the tail.
Okay, so clean tip is Wuchereria, two marbles is Brugia, and finally, Loa loa, the African eyeworm.
Also sheathed. But the nuclei go all the way to the tip. It's messy, it's crowded, filled to the brim with nuclei, right to the very end.
That specific distinction is so high yield for the boards, you will undoubtedly see a zoomed-in photo of a tail and be asked to ID the worm.
And clinical context always helps too. Wuchereria is strongly associated with genital lymphatics and hydrocele. Brugia is mostly restricted to the lymphatics of the legs and arms. Loa loa involves the eye. You can actually see it crawling across the conjunctiva and causes calabar swellings.
And Loa loa is diurnal, right?
Yes. Unlike the others, Loa loa swarms the blood during the day, so you actually want a daytime smear for that one.
There is one more filarial worm we have to discuss because the treatment for it reveals something amazing about their biology. Onchocerco volvulus, the cause of river blindness.
Transmitted by the Similium blackfly. It causes these large subcutaneous nodules and eventually leads to severe corneal scarring and blindness. But the real breakthrough in creating it came when we realized these worms have an endosymbiont.
They have bacteria living inside them.
Yes, a bacteria called Wolbachia. It turns out Wucheria brugia and Onchocerca cannot survive or reproduce without these intracellular bacteria. They're entirely dependent on them.
So this opened up a kind of Trojan horse treatment strategy.
Exactly. Instead of just using harsh antiparasitics, we use doxycycline, a standard antibiotic. You kill the Wolbachia bacteria, and the worm becomes completely sterile and eventually dies. It really transformed how we approach treating these diseases.
That is just brilliant. It just shows how interconnected these biological systems truly are.
It does. And speaking of treatment, just to quickly recap the pharmacopoeia for the exam, for most of the broad-spectrum intestinal worms like Ascaris, hookworm, and Trichuris, we use the benzimidazoles, like albendazole.
Right.
For strongyloids and Onchocerca, we use ivermectin. And for the lymphatic filariasis worms and Loa loa, we use dithylcarbamazine, or DEC.
Before we wrap up, let's just test this knowledge with a few rapid-fire scenarios. I'm going to throw a quick case at you, and you tell me the worm and the diagnostic key. Ready?
Let's do it.
Case A. A 6-year-old child, restless sleeper, constantly scratching their bottom.
Enterobius vermicularis, pinworm. Do the Scotch tape prep first thing in the morning. And remember the QA rule.
Yeah.
Keep testing for 5 consecutive days before you call it negative.
Spot on. Case B, a Peace Corps volunteer just back from sub-Saharan Africa. They have transient swelling in their wrists, and they mentioned seeing a quote-unquote floater actually moving across their vision.
Loa, the African eyeworm. You want to do a blood smear, but do it during the day because it's diurnal. And on the smear, look for a sheathed tail with nuclei extending all the way to the tip.
Excellent. Case C, a patient with severe abdominal pain, eosinophilia, and a history of being treated for lymphoma with high-dose steroids. They are deteriorating fast.
That is the nightmare scenario. Strongyloids hyperinfection syndrome. You need to look for live larvae in the stool, or in severe cases, even in the sputum.
Check for the short buccal capsule.
Exactly. Differentiated from hookworm with that short buccal capsule. And get the ivermectin ready immediately.
It really all comes down to understanding the life cycle.
It does. It's about thinking like the worm. If you know where it wants to go and exactly how it reproduces, the diagnostic test becomes completely obvious. If it lays eggs on skin, use tape. If it migrates at night, draw blood at night. If it eats muscle, biopsy the muscle.
I want to leave our listeners with a final thought that goes back to that strongyloids discussion. We talked about how it can hide in a host for 40 years, totally undetected, through autoinfection, just waiting for the immune system to slip.
It's a chilling survival strategy.
It makes you realize that health isn't just the absence of symptoms. It is an active daily war that your immune system is fighting to keep these dormant invaders in check. It really makes you wonder what else might be waiting in the shadows of our biology, just biding its time.
That is exactly the question that keeps parasitologists up at night.
On that happy note, good luck on your board exams. Keep your cellophane tape handy, and we will see you on the next deep dive.